Next, we invite Dr. SUJEET RAJAN. Dr. SUJEET RAJAN is practicing respiratory physician in Mumbai, India. He graduated from the Grant Medical College in Mumbai in 1989 and postgraduated in respiratory medicine from the St. G.S. Medical College and AEM Hospital. He also holds a diploma in environmental tuberculosis and respiratory diseases. Sir is at Bhatia Hospital, the Mumbai Hospital Institute of Medical Sciences from August 2000. He has been actively involved in research and clinical practice at these two hospitals since then. His special interest is in the intestinal lung disease, where he currently is principally investigating in 3 global clinical trials related to newer drugs for IPF and progressive pulmonary fibrosis in non-IPF ILDs, as well as CT imaging in ILD. Sir is here to talk on complication in lungs and ILD in scleroderma. After the presentation, one of our scleroderma warrior, Mrs. is sharing her experiences, how pulmonary rehabilitation helped her. Over to you, doctor.
Hi. Lata, can you hear me?
Yes, sir.
Great. So, thank you, Rashmi, for inviting me to this meeting. And I hope after some great talks and a patient perspective, I can shed some light, which I feel this group is pretty well informed. But maybe I can tell them a little more about the lungs that they may want to know. I know we don't have Q&A, and so I can always take questions by email if there are pertinent ones later. So let's talk about systemic sclerosis in the lung. And what we need to really worry about in scleroderma is pulmonary hypertension, which was discussed a little bit by Dr. Rath, interstitial lung disease, renal failure, and reflux. So these are things in scleroderma we really need to be concerned about. And when you look at the lungs, these are the parts of a lung that you need to understand what is happening in your lungs, because sometimes you have an airway problem, sometimes you have a structure problem, and sometimes you have a problem in the lung vessels, which is the pulmonary arteries. And so these 3 components of a lung are different and need to be understood in with different perspectives. Now, the airways are the simplest part of the lung. If I just tell you briefly on the airways, they're rarely involved in scleroderma, but you should know about what the airways are. This is how the lungs look like. Then we have airways which are balanced and branched out into the lungs, and they can be, as you can see in both the lungs, the red parts are the airways, which are like a tree turned upside down. And airway disease is pretty easy to treat because asthma is a typical example of an airway disease, where when you get into the airways, you take an inhaler and you're fine, right? So airway disease, when the airways are narrowed like this in COPD and asthma, the lungs and they just sort of distend. And to actually show you, if you cross-section these airways are swollen, and you take an inhaler and the patient in asthma comes back to the diagram that you see on the left-hand side, lungs expanding well. So it's pretty easy to manage airway disease is what I want to tell you. But when you come to the structure of the lung, or the real meat of the lung, as I would call it, that's a little difficult to understand and treat. And that is what gets affected, or what we call the interstitium, as was explained. And that's an area I have a lot of interest in, and I spend a lot of my day involved in interstitial lung disease. And the interstitium is, like you can see in this diagram, a thin lining inside our lung, which transfers oxygen into the blood. So the airways just bring the oxygen to the lung. And so they are a conducting mechanism. But when you actually look at transfer into the blood, then it occurs via the interstitium. And therefore, one of the tests to understand the interstitium is called the DLCO, which basically measures how well this interstitium is functioning. And if you've ever done a lung function test, which many of you all may have done, then your DLCO will tell you how well this interstitium is functioning. The area of the interstitium is huge. It's if you stretch out this interstitium, the area is as big as a tennis court. And you can imagine how much interstitium we have in our lung. But when that gets significantly affected, that's when you have, excuse me, just a apologies. So when this interstitium that you see here, it can get affected in two ways. One is that it can get swollen, as you can see here in the middle. And the other is it can get fibrosed or scarred. Both of these situations cause a problem in getting oxygen into the blood. Okay, so this interstitium, to make it simple, transfers oxygen into our blood. And so inflammation, as the middle diagram shows, is something that you can potentially reverse. As you heard the patient perspective earlier on stem cell, and we hope her inflammation in the lung has reversed. But once fibrosis occurs, there is still no drug available, unfortunately, to reverse that fibrosis. So for inflammation, you have steroids, azathioprine, mycophenolate, and cyclophosphamide that have been tried to reverse the inflammation with somewhat decent results, but not fantastic results, unfortunately. And for fibrosis, you have now anti-fibrotic drugs available that slow the progress of the fibrosis. And that's a very important aspect of interstitial lung disease that you need to understand. You have heard of fibrosis in the lung, and many people get scared about it because they hear about a disease called IPF, where fibrosis occurs in the lung without a cause. And when it happens without a cause, it progresses without a cause, and that's dangerous. So you obviously have a person who's progressively getting worse and worse fibrosis. Scleroderma lung fibrosis is different in that usually the patients are younger. IPF happens in older patients, females more than males, and other systems also tend to get involved. The skin, as we know, and sometimes the joints, and sometimes the pulmonary vessels, and the renal system. But IPF affects only the lung. Also, autoimmune serology is positive, and that's why autoimmune therapies or immunomodulation is given in scleroderma, unlike IPF. And IPF progresses much faster than scleroderma. So that's the difference. So don't get worried when you read about IPF and a 2 to 5 year survival, which you will read on the internet. Scleroderma fibrosis progresses slower. So how many patients get it? Out of all fibrosing lung diseases that I see as a lung physician, about 9% of all these diseases, 9% of these patients are scleroderma with ILD. And this has been, and the NSIP, or the pattern on the scan, is usually NSIP and not UIP. That pattern, the UIP pattern, is seen in IPF. And 40% of these scleroderma lung fibrosis patients have a progressive phenotype, and therefore they can progress. And the adverse prognostic factors are diffuse skin involvement, less than 7 years since the diagnosis, black race, the presence of antibodies in the blood, male patients, and a disease extent more than 20% or a reduced vital capacity and DLCO. So these are signs that you need to now get the fibrosis treated or prevent the progression. You monitor, obviously, on cough, dyspnea, the breathlessness, skin thickening, examinations, and lung function. Lung function is extremely important, and sometimes I feel done less often than required by rheumatologists. I know we have rheumatologists on the panel today who do it periodically and regularly, but you do have rheumatologists who don't monitor lung function as closely as we would like them to. So vital capacity, FVC, DLCO, and a 6-minute walk test every 3 to 6 months would be great, and a high-resolution CT scan as and when needed, and not regularly. The first studies were the SLS1, which was done in only one country, in the United States, and there was no criteria for fibrosis scoring on the scan. Cyclophosphamide was given. A lot of patients dropped out due to side effects. Mycophenolate was tested here, and in another study, and then because we needed a longer-term option than giving IV cyclophosphamide every 3 weeks, 4 weeks, that was then SLS2. And then SLS2 basically studied mycophenolate with cyclophosphamide, and MMF was tolerated better. So many of you may be on mycophenolate for that reason. However, neither mycophenolate or cyclophosphamide is approved for scleroderma ILD. CT, there's on all these studies, there was no scoring of the fibrosis, and you expected vital capacity to improve, but it didn't improve. And the effect peaked at 21 months, whatever little improvements were there. And so the interest has now been on fibrosis and scleroderma, and that's the area where a respiratory physician gets involved. And when you have no fibrosis on your scan, your prognosis is very good. Whereas even a little fibrosis increases your risk of mortality, or the SMR, the standardized mortality ratio. So lung fibrosis, whether it's not there, 5%, 10%, or even a small amount of fibrosis is worse than no fibrosis. And so as that fibrosis extent increases, you have a higher risk. And therefore, the antifibrotic should come on the moment you see fibrosis on the scan. The census studies, which many of you all may have heard of, excuse me, was done in 32 countries. India participated in the census trial. And that trial showed that an antifibrotic drug, nintedanib, actually slowed the decline in vital capacity. And this was huge. I mean, 44% relative reduction versus placebo. And this treatment effect is meaningful because this starts at middle age. And so therefore, there is smaller annual decline, which accumulates over several years. And we know that FVC dropping is associated with mortality. And this effect is the same whether you have a lot of fibrosis in the lung or minimal fibrosis. And so therefore, this is an important treatment that we need to understand. In patients who are on mycophenolate, so PBO is placebo and NIN is nintedanib. So if the patient was on mycophenolate, the drop was even less when it came to the vital capacity. So there's no harm in continuing both these drugs. Hepatotoxicity or liver toxicity could be slightly higher, but the studies did not show that it was higher because the way they are toxic to the liver is in different mechanisms, and that's why you don't have a problem there. And the third part of our lung, excuse me, is the vasculature. So that was about the structure of our lung, and now the vasculature, or the pulmonary arteries. And this is another part you should understand, and that is pulmonary hypertension, which we've been hearing a lot about in the last 10 years. About 10 years or 15 years ago, we had a blank slide on treating pulmonary artery hypertension, literally blank. And in the last 15 years, we've got multiple treatments now for pulmonary artery hypertension. For those of you who want to know a little about this, you saw on the initial slides from Dr. Rath about the heart, the right atrium, the right ventricle, LALV. Let me make it a little simpler for you. The left ventricle is our blood pressure. Okay, the pressure is 110/80. You need a blood pressure instrument to check the pressure. And you know the pressure in your left ventricle, which pumps through the aorta to the entire body. The right ventricle is a much smaller chamber, 1/3 the size of the left ventricle, and it pumps through the pulmonary artery to the lungs. And as you saw very elegantly on those earlier slides that Dr. Raj showed, the pulmonary artery sends the blood to the lungs oxygenate them and bring them to the left atrium, left ventricle, and then it's pumped to our entire body. So if all of you all remember a little science, I'm sure you remember this. Right ventricle, the pressure is 25/10, and you cannot measure this pressure with a blood pressure instrument. You need more tests, and the echo is one of the best screening tests for this. So you cannot find out this pressure by checking blood pressure or clinically examining the patient. When pulmonary hypertension develops, the right ventricle pressure goes up, and it goes up to say 85/30 sometimes, and you need a right heart cath or an angiography to study the right side of the heart to accurately get this pressure, which I would recommend for any patient who is a strong candidate for pulmonary artery hypertension to get done, a right heart cath, which some of you all may have got done. When do you start feeling giddy in scleroderma, or you have blackouts, is when that right ventricular pressure goes over the left ventricle pressure. So when the pulmonary artery pressure is higher than the left ventricle, then your blood pressure drops. Then you get those blackouts. So you don't want to be diagnosed at that stage. You want to be diagnosed much earlier because you can treat this so much better. 15 to 20 years ago, trust me, a lot of patients with pulmonary hypertension and scleroderma were going for heart-lung transplant. Today, that whole scenario has changed. Very few need to go for transplant because of treatments available now for this pulmonary artery pressure. The treatments in pulmonary hypertension are those that are exclusive to the disease and patient needs. If you ask me, both are important. Patient needs are more important, and I'll come to why that's more important. When you look at exclusive to the disease, you have the treatments. And I don't want to go into a detailed talk on the drugs. I'm sure many of you know about these drugs: sildenafil, tadalafil, endothelin receptor antagonist, bosentan, prostacyclin receptor agonist, iloprost, IV epoprostenol, and hopefully we'll get these inhaled prostacyclins soon. And soluble guanylyl cyclase inhibitors, riociguat, which is now available in India. So these are the drugs that are available for the treatment of pulmonary hypertension. Some of you would be on these drugs, and those who don't have pulmonary hypertension will not. Those of you who have digital ulcers will probably need these drugs, even if you don't have pulmonary hypertension. One of the landmark trials for this was the inhaled treprostinil trial, which has now been used in pulmonary hypertension due to ILD. So being an ILD specialist, this has been a huge breakthrough because a lot of ILD patients get pulmonary hypertension. And inhaled treprostinil is one of the first approved drugs to treat pulmonary hypertension and ILD. Unfortunately, not yet available in India. But we're trying hard through people in the foundation. When it comes to patient needs, I find these more important because as the disease advances, and you may know patients with advanced lung disease, advanced pulmonary hypertension, friends, colleagues, someone known to you, there's a lot you need to do, whether it's rehab, oxygen at rest. Oxygen is a drug, and it should be used correctly at rest and on mobility. So some people have a normal oxygen saturation at rest, but drop on exercise. Some people drop only at night, and you can do a test called the overnight oximetry to check whether you're dropping at night and use oxygen only while sleeping. So using oxygen should be done correctly, and not like I have seen some prescriptions which say use for 1 hour in the morning, 2 hours in the night. That makes no sense at all. So you need to know your oxygen saturation at rest and on walking to accurately prescribe this. Rehab is extremely important here, but under a supervised physiotherapist who understands cardiopulmonary rehab well. And there are some great physios and rehab. And now a lot of rehab has moved online. So there are online cardiopulmonary rehab physios who can teach you how to do this in the best way possible. And it should be ideally a physiotherapist who's MPT in cardiopulmonary rehab. That's the best type of physio to enroll. Management of reflux because of esophageal dilatation, that's equally important. And those are things that trouble the patients. Vaccinations, pneumonia, annual influenza vaccine, and now just available since 2 months, the herpes zoster vaccine. Please ensure that these are taken. Herpes zoster, especially if you're above the age of 50. That's when herpes zoster vaccine is routinely recommended for the general population. So a scleroderma patient, in my view, is even more important to get it, and available now in India. Supportive and palliative care, which I will talk about, and of course, referral for transplant. Vaccination, I cannot tell you how critical it is and how often it's forgotten, because one bad attack of flu or COVID can really set you back. And, you know, like a patient with heart failure gets half a dozen drugs prescribed to them the moment they're diagnosed. 2 vaccines to prevent respiratory infection are often missed. And so you need to ask your doctor whether you should be vaccinated. And I cannot tell you how important this is. 2 different types of pneumonia vaccine 1 year apart, and another booster pneumonia vaccine after the age of 65, and a flu shot, quadrivalent, Southern Hemisphere strain for Indian patients once a year. And the herpes zoster vaccine for those over 50, 2 doses, 2 to 6 months apart. Finally, palliative care medicine. Palliative care medicine is often misunderstood as hospice and end-of-life care and is perceived as giving up on the patient. And I've had a lot of doctor, physician colleagues who think that palliative care is all about end-of-life care. And this is a huge mistake. I think we need to understand that palliative care, or supportive care as I like to talk, is something that goes hand in hand with the regular treatment. Rehab, all this is part of palliative care. You want to have a better quality of life as well. Whatever new treatments are available, your quality of life is as important, if not more important. And as I would say the first author of the palliative care consensus statement in the Lancet wrote, the only thing worse than chemo, and I thought this was such a pertinent point, what is worse than chemo in cancer is not having the choice to have chemo. And I think this reflects so much on what patients want. I mean, they want to choose what they would like to get, right? And so never get forced into doing something by anyone, especially your physician. Ask them the questions so that you get answers that you're comfortable with. And if you're not comfortable with it, please do have another discussion with them, or go to a physician who's happy to give you the time to discuss these things. And when emergencies happen in very sick patients, there are so many things. Half of the time, not half, most of the time we are having these discussions outside an ICU in very sick patients about whether they should be ventilated, CPR given, and I think these should be done in advance. And, you know, sometimes relatives tell us, you know, do everything. And as someone said, I wish more people knew the misery of doing everything. So it's a branch of medicine, and all our patients with advanced lung disease meet our supportive care consultants. So we manage them as a team because we believe that there's one thing that you can do for a disease. There's another thing you can do to improve the quality of the life of the patient. What do patients want from a physician? This was a Yale study where patients were asked, what do they want from their doctor? And they said, a doctor they can trust, a doctor who's competent, and a doctor who puts their priorities before anything else when they make a management plan. And you would be surprised to know that 2 of these are not taught very often in our medical colleges. We are taught to be competent doctors, but we are not taught how to build trust in a patient and how to put the patient's priorities before anything else. At least I wasn't taught, and I still see this is not being taught, barring a few situations where you have great mentors who tell you that this is important. But we are taught so much about disease that we believe when we come out of medical college, all we need to do is cure disease. And we forget about the patient in front of us. These discussions often happen 3 days before a patient dies, and that is hardly the time that these discussions should happen. The triggers to begin talking about palliative and supportive care are elderly patients, when patients are dependent on their families, very minimal activity, oxygen dependency, dependency on ventilation, bi-level PAP, non-invasive ventilation, or they've been hospitalized more than once in the last 1 year. And that's why I'd like to conclude on shared decision-making. We have much better drugs for scleroderma than we have ever had. But shared decision-making in many diseases now has become a model for clinical practice, where the doctor tells you all that is available and you tell him what your priorities are. And then you take a shared decision. And I would encourage patients to spend that time with doctors discussing what their priorities are, so that the best possible decision can be made in their best interests. Finally, the last slide on what I'd like you all to take home. Lung involvement in scleroderma is not always the case, but it can happen and it needs attention. So protect your lungs in scleroderma, be alert. Important here is a good scan. And if you're looking at tests to understand lung and how badly they're affected, you need a good quality scan and a good report. And Kaushik will also vouch for this, that if you don't have a good CT radiologist, you're going to get a poor quality scan and a report, because he doesn't ensure his technician does the scan well. And we have seen 60 to 70% of scans that come in for a second opinion, poor quality. So there is an ILD protocol by which your scan should be done. And if anyone needs that protocol, I will send it to Rashmi to send it out to you all, to tell your rheumatologist, chest physician to get the scans done that way. Then you don't have to repeat a scan, at least the quality is okay. Then the reporting has to be done well. Then only the reporting part is left. So you can send the DVD soft copy to a second CT radiologist if you need a second opinion on that scan. Is there fibrosis? How bad is it? Echo and right heart cath, very important. You could spend a whole day on this, but I can tell you echo is a good screening test. But in scleroderma, where you suspect pulmonary hypertension, one right heart cath is important. Immunomodulation and PAH treatments are important. We've heard about them and you'll keep hearing about them. They're new drugs, and that is so heartening to note. So we can slow progression of the lung involvement